Welcome to Health Literacy Matters. This is an overview of health literacy. Today we're going to talk about the key concepts of health literacy. We're going to talk about how to recognize some red flags of low literacy or limited literacy. We're going to define what universal precaution in terms of health literacy means. I want you to be able to identify at least one practice or strategy that you can apply to health literacy that is a universal precaution. So we'll kind of go over it. How many of you actually had heard the term health literacy a year ago? Okay, there's a couple. How many had never heard about it until you actually were going to take this training? And that's okay, because health literacy has been around since 1974, the term, and while people talk about it, it hasn't really gotten a lot of attention and a lot of research behind it. Over the last almost 50 years of the research, there is some really good strategies coming out of it. But first, let's back up and even just say what literacy means to you. If I say literacy, what's the first thing that usually pops to mind?
Reading, writing.
Yeah. And so my former life, I was a director of admissions at a community college. And that was one of the things that was in my wheelhouse, was to actually do the assessments of reading comprehension, their writing, and then their mathematics skills to see if they were going to be at college level. What I never really kind of thought about is when you look at it, the comprehension is really what's important. And talking about the printed and written information that we use to function in society. I was driving here today and I was thinking about all the stop signs and the different signs telling you the pedestrians. About 6 months ago, I was in England, and it's a completely different system with all the signs. And while I know that we all have our generalized signs and we think they all make lots of sense, it was going to take me a little bit to get used to it. And that's the same thing in our society, is that we have all kinds of different written on the internet, paper, signs, communication, even having a verbal conversation with somebody can go to their literacy of can they understand that. So it's really important to realize that it's not just about reading. And so when we apply that to health literacy, we have the same dynamic that we need to look at, is that we need to realize is that it's not just their ability to read the information that we hand them, but it's also the social characteristics, their environment, what's going on around them, how they can actually process this. So this is the definition that was back in '74, where it talks about required for individuals and communities to access, understand, appraise, and use information and services to make decisions about their health. Now in '74, they did a really nice job of including the community in there. But in 2000, when the research started to kick in, you have to come up with a definition so you can measure it. And so in 2000, this definition is the most widely used definition now that we see. And it appeared in the National Assessment of Adult Literacy back in 2003. And that's where a lot of our research goes back to when we talk about health literacy, because there isn't a lot of actual research on that actual topic. However, this one talks about it's the degree which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. I've been to the doctor in the last 6 months. How many of you have been in the last 6 months to a year? How much information was given to you during that meeting? Was it a lot? Show of hands if it was a lot of information. How many had a little information and you were out real quick? So our experiences are all different. And our physicians and our health professionals all go about it in different ways. And so some people have the capacity to have something handed to them, walk out and be able to go back home, look at it, and make all the decisions that they need. Other people, that's not the situation. And you know, a lot of times we don't stop to think, we don't all learn the same way. How many of us are very aware of how we each learn? Some are better auditory, some are better visually, some are better, I need to touch it and do it and actually go through. How many times do we actually get that experience in your doctor's office or when you're interacting with a health professional? Has someone asked you, how do you learn best? Because that should then gear you towards, oh, I'm going to hand this to you. Or I'm going to, like, I've had knee surgery, so I really like when they pull out the little knee thing and they can show me what ligaments they're talking about, because when they start using all the proper names, I've lost it. I'm like, I don't know where that is, kind of a thing. So that's what we need to think about, is that it's not just, can somebody read the forms? How many of you have gone in and seen a new doctor and had to fill out your history? Is that fun? I find it so annoying, especially when I go, I'm not going to say which organization, but I went to them because they're supposed to be connected to everybody, all of my physicians. And yet, every single time that I go to a different one, I have to fill out all that information again. Now, I just went like 6 months ago, and I had to fill out the paperwork again. Now, here I am, I'm teaching health literacy, and I have a health and phys ed degree, and I've done all this stuff. I get sit down, and one of the questions is about family history of heart failure. Well, my uncle had a heart attack, and my grandfather had a heart attack. Is that heart failure? Or, you know what I mean? And like, so, like before I'd seen it as heart problems or cardiac or whatever, but all of a sudden that one word threw me. So thinking about it isn't a matter of whether or not you have a high school diploma, a college degree, a medical degree. It's about whether or not you have the capacity at the time to actually be able to obtain, process, and understand those basic concepts that you need to make your decisions. The Minnesota Health Literacy Partnership is a really amazing resource, and I suggest that everybody go to their webpage because they actually have all of these presentations on numeracy, Health Literacy 101, Teach Back, Plain Language, Ask Me 3, and they give you the guides. They tell you how long it's going to take to actually teach it, and they do a pretty good job of expanding it beyond just the individual. Because in the last 10 years, what we saw happen is that research said, it's not just the individual that we need to be concerned about what their ability is. Because the problem is, when somebody says, oh, I'm going to pick on you, JD. JD has an 8th grade reading level, and he's really struggling with the information that we gave him. Sometimes a knee-jerk reaction is to send JD to the literacy volunteers to try to help him improve his literacy while we hand him the same packet and hope that somebody will help him with it. Well, assessing each one of our patients is not feasible. The different modes of tests range from 1 question to 99 questions. And there are also, it's expensive, and what do I do now that I found out that JD had an 8th grade level? Did it change the way I was doing business? So the expanded definition looks at what our capacity is to communicate clearly, educate about health, and empower our patients. So it's a partnership. So when JD comes in, If I'm sitting down with him, I need to be doing, and we're going to get to it, the universal precaution, is that I'm going to assume and make sure that everybody understands and check for understanding and assume that they may need some clarification. So when I sit down, I want to be asking, how do you learn best? You know, we're going to talk about the teach back. We'll talk about some of the others, but it's my responsibility, it's your responsibility to be able to communicate it clearly. You know, if we had more time, we could do all those types of exercises that I'm sure you've done in other trainings where on communication, about how you have to draw something with somebody's got their back to you and you have to draw it and they're telling you exactly, or you put Legos together with how somebody's telling you but you can't see them. A lot of times we get doing the same thing over and over and we think we're being really clear. And actually it's not clear to the person that we're talking about to. How many, I do this a lot sometimes, somebody doesn't understand, so I just say it again the same way. And I say it again the same way. It's like, well, they didn't understand it the first time that way. Just because I said it repetitively the same way is not going to make a difference.
Sometimes people get louder.
Yes, louder. And you know, the other thing is, how many of you are pretty busy every day and have a pretty hectic schedule? And when you're running and you're going from patient to patient or person to person, client to client, sometimes our patience level kind of sinks and people start to get annoyed or frustrated. And I can tell that you don't understand what I'm saying, so I'm going to say it you know, again. So it's all about how we're communicating and empowering. And the interesting thing I've learned about health literacy is it all comes down to communication. Everything that I've looked at, all of the different strategies that we're going to take a look at, all comes back to communication. How do we facilitate it so that our people that we work with feel comfortable to talk to us? And how do we do it in a way that's most meaningful to them? So I'm going to do a quick example for you. So we're going to have a minute. And we're going to, as a group, read the next slide out loud together, okay? And so we're going to go ahead and get started. So go ahead and start. It's backwards. I'll give you a hint that it's written backwards. So go ahead now. Can you see?
Periodically clean tape heads.
All right, you got 30 seconds left.
An accumulation of dust.
And we're going to have to ask you questions about it afterwards.
An accumulation of
Okay, we can stop. So, did everybody get that it was cleaning to assure high performance? Periodically clean the tape heads and capstan whenever you notice an accumulation of dust and that's supposed to be brown, red, oxidized particles, and so on. How did it feel doing that exercise?
Well, I read cleaning and I didn't even bother to read the rest because I just assumed it was a definition for cleaning, which was incorrect because it was just instructions on how to clean something. So I just made an inference right away. I was like, I know what this is.
That's and actually that's a perfect example. Anybody else? What else happened?
I thought it was in Latin, the first two words after cleaning. I was like, no, not my expertise.
So you just kind of quit because you're like, I don't even know it, so I'm not doing it. How about other people?
I just shut down and hid back here and listened to the rest. So if I was in a group and that was going on, I was just like, okay, let those guys figure it out.
Right, and I'm going to kind of fly under the radar, not let anybody know that I'm not quite getting that. Was anybody frustrated? So that's sort of what it's like for somebody who has low literacy going in and trying to read the information that we're giving them. Those forms that they have to fill out, even though they may have seen some of them, like for me, when I first figured out how to read it backwards. I started to kind of speed along until I hit like oxide and particles and isopropyl alcohol. You know what I mean? Like the ones that are more technical. So think about that with the folks too that are reading, is they might, oh, go ahead.
Yeah, and even if I was able to read it, but I couldn't have told you what it was about. But I mean, I read it.
Yes.
But
Perfect.
would not
I was
have
going to say you
able-
wouldn't have been able to answer
I
the
wouldn't be able to
question.
do what it said.
Right.
By any means.
Perfect. So that got exactly what I was looking for, is that even though somebody could read it, they might not have the comprehension. They're going to give up. They're going to fly under the radar. They're going to make assumptions and just skim through and do it as quick as possible. So that is just a moment to step back and see where that the compassion is for the people that we work with, and realizing that this can be a frustration. The other thing is that what grade level do you think most of our materials for medical information or health information is written at?
College level.
College level, anybody else?
Probably 12th grade.
12th grade. What grade level do you think most Americans read at?
5th.
4 to
Third.
6.
I was thinking like 6th and 8th grade.
Yes. So a lot of times people will adjust down to 8th grade, but it actually shows that it's more between 4th and 6th grade. And for a lot of people, that's really hard to believe. And
I said spend time in the school.
I was going to say, as a director of admissions, again, I'm going to refer back to it. And I'm not going to say which area I worked in because I don't want any of the school districts to be identified. But they would be, I think, really embarrassed if they had had their high school graduates, recent and past, actually to show their college, or what the English, writing and comprehension in the math, they were not coming in at college level. Now you may think, oh, it was a community college, so you were getting the students that weren't high in their class. No, we were even getting some of the students that had honor roll grades that were not coming in with that. The other thing is that folks who've been away from school for a really long time, you have to think about that too. One of my other jobs that I used to do is help people retrain after they've been laid off from a job and go back to school. And so one of the assessments they had to take was a TABE test, and it had to show what their reading and the math was again. I worked with a 58-year-old man who had been working for the last 40 years in a factory and doing really well. And when he came out, though, to take the test, he hadn't been in school in 40 years. So trying to take those tests, it was not reflective of what he was able to do and how he was functioning in society and those type of things. So that's something to remember too, is that you might have somebody that's sitting in front of you with a college degree, and they might not have that same reading capacity that you think they're going to. From that National Assessment of Adult Literacy, they have found that only 12%, or 1 out of 10 people, are actually proficient in health literacy. And that means somebody who can figure out their health insurance, like who their HMO is, what their contribution is, how much they're going to pay. Think about somebody who has to go and fill out Medicare forms. Has anybody helped somebody with that?
Not even the forms, just the language.
just the
alone
language,
and
yeah.
the pieces of it.
Yes.
So think, all of those systems, do you know what I mean? And like, my wife is an LPN, and so she should have a high health literacy. And yet, when I found out that she wasn't using the right doctor in the tier, because I was like, why are we paying for this? And she'd been using the tier 4, and she had no, you know what I mean? So you can't make an assumption that somebody's going to be there. So that means that what are we doing for the rest of the people who are not at the proficient level? So you'll see the 12%. So back in 2003, that was about 25 million people that meant was proficient. 53% was at intermediate, but 36% was at below basic, or basic. That was 77 million people back in 2003. Now, if we look at today's population, that's more like 118 million people that are at basic or below. That means somebody is challenged with, take 2 pills a day. When do I take it? They're challenged with their discharge instructions. How many people are now seeing that, like, they don't want you in the hospital much anymore? They want you out. Knee replacement. Used to be 3 to 5 days you were in the hospital. Now it's the next day, get out, whoop. And they're sent home with all of these instructions. On the one hand, it's for patient safety because you don't want them to get infected and get infections and all that other stuff. But now you're making sure, you want to make sure that they're going home and they really understand all the things that they're supposed to be doing. We have such a reliance on our written word today. How many of you have left either the doctor's office, the emergency room, or a health appointment with a printout that tells you what to do? And they say, okay, you're all set, here you go. If you have any questions, give us a call. Or go on the webpage there and it'll tell you exactly how to do that. The hard part is that we really want people to just read about it. We also have a really increasingly complex healthcare system. We just talked about a little bit with Medicare, but I mean, all of the insurance, all of the hoops you have to jump through if you want to see this doctor, but go to that one. The other one, the other day, I'm not going to lie, I was doing it. I was Googling on my phone what the difference was between convenient care, urgent care, the walk-in, because I had an issue that I knew I couldn't get to my doctor, but I needed to go. But it wasn't an emergency room thing. But I also had the teledocs. Should I use that? So there's all these different options. There's also so many more tests and procedures that are available today than ever. Last year I took an end of life issues course, and it just blew me away. I had no concept that intensive care units were not a thing of the past. They're more of like in the 60s and 70s, where then now every hospital has that. And so we don't really think about it, but even think about all of those life-sustaining treatments and things, and about the complexity of that, and do we understand what we're asking for. We talked about the growing self-care requirements. Do you know 30 years ago that if a diabetic was diagnosed, they would have been admitted to the hospital for 2 weeks, and they would have gotten 2 hours a day of education and training? What happens now if somebody is diagnosed with diabetes?
You get a piece of paper and you get sent home, because I just went through it with my husband. And thank God I worked health field, so I knew what to do.
Yep, and hopefully you have somebody that'll at least refer to the nutritionist and the education, but what if those people don't know how to get there, are scared, all of those things. So that's another reason why, we get frustrated with our repeat people coming in. They're like, oh, they're not doing what they're supposed to do. Their numbers are way off. That isn't just because they're necessarily want to be non-compliant. I hate that word anyways, compliant. It's not that they're not trying to adhere. They may not understand how to do that. And I don't know about you, but for me, if I don't understand why, it's not always important to me. Do you know what I mean? I have to understand and really get the sense of it, of why we should be doing that. And esoteric language, what is that? Does anybody know what esoteric is?
Where only a very few people know that have access to that information.
Exactly. So I have a family full of nurses, chock full. And so when I don't feel well, I get, are you diaphoretic? Oh my, what are you talking about? Are you clammy and sweaty and whatever? And I'm like, well, why did you not just say that? Or, they're trying to tell me what medication to take and I have no idea. But every field has it. When I worked in the college, admissions, Pell, TAP, all of those things that you just take for granted. The medical field, how many acronyms are there?
DISRIP is a second language.
Oh, DISRIP in itself. I'm always stop and I'm like, oh, please don't ask me what that stands for. And so when I started in the gerontology field, there was a whole nother list of all these acronyms. Thank goodness I knew the director of the Office of Aging, and I said, do you have a cheat sheet? And she sent me a cheat sheet because I was getting, there was CAPS and CAPC and CMC, and I mean, there's just too many that I couldn't keep straight. But so that's what we have to remember too, is that you might have an engineer sitting right next to you, and he's highly educated or she's highly educated. But if you start in with hypertension or some of the other big words, they may have no context for that, and we forget as professionals, especially in the medical field, hands down, they learned 11 to 13,000 terms that the rest of us do not use. Do you know what I mean? They have a whole nother language. But so we have to make sure that when you're meeting with your folks, that you're bringing it back to the plain language. The most at risk is probably not a surprise, but the elderly. So anybody is 65 and over, they lead the way. Why do you think some of the elderly may be most at risk?
Because of the exponential growth with changes in technology in the healthcare field. So what they knew about their potentially, health or chronic disease has changed significantly over the past year,
Yeah.
let alone 10 years.
Yeah.
Social isolation.
That can be where you find your information. There could be cognitive changes, hearing impairments, vision impairments, multiple chronic illnesses, trying to manage multiple things at the same time. They were also raised in a generation where the doctors were the only ones who had the information. So what the doctor said was word. So they're not used to being in that situation where they actually feel like they partner all the time, and that's a generalization. Obviously not all folks over 65. But we also, 10,000 people a day in the United States turn 65. So that is a lot of people that we have to make sure are getting the information that they need. Ethnic and racial minorities, limited education immigrants, low socioeconomic status, and people with chronic disease. A lot of times we see the limited education is one of the things that people like to do as a checkbox for health literacy. They have an interpreter. But you have to make sure that the interpreter as well has had health literacy and making sure that they're checking for understanding. For example, fatiga can mean in Spanish, it can mean tired, and it can also mean shortness of breath. And so you take a 55-year-old man who comes in the morning to the ER and tells them and says, I've had fatiga. And the nurse first hears fatiga. So you've been tired, how long has that been going on? And then the interpreter comes in, so he's been tired. And so they make him wait because they think he's just been tired and all this stuff. And then 5 hours later, he suffers a massive heart attack because he was having the shortness of breath. But if you go back and you have the interpreter say, oh wait, I just want to clarify, are you short of breath or are you tired? And that makes all the difference because then the treatment and how they do it. So it's not just about having an interpreter. It's about making sure that that clarification and understanding is occurring. 59% of folks over the age of 65 have basic or below. And social determinants, that's something that if you haven't spent a lot of time with health equity, you need to take a look at because that can be one of the biggest determinants of our health. Health literacy is actually one of the health and healthcare indicators. But economic stability. If you grew up in a family where you didn't have health insurance and you only went to the doctor if you were bleeding or severely ill, your preventative wellness is probably not where it needs to be because you never were raised in that kind of situation. If you don't have the money to actually go and access some of these services, that can be an issue. Transportation, if you cannot afford to get there, that is a big thing. Like people forget. Like, if you're taking the bus, each time you get on and off, and each time this happens, does the bus run at the time when you need to get there? How many of you have taken the public transportation? Come on. I grew up in the country. I find it overwhelming to look at the bus schedules. So for a country girl, I'm like, whoa. But so think about some of the apprehension that somebody might have over that. In rural, let's throw that out there. There isn't even a bus that goes there. Education, that can be also an indicator. Your neighborhood. How can the neighborhood be a social determinant of health? Think about if housing. That's a huge part of it. If you don't have safe housing, safe neighborhood.
Walkability, accessibility.
Yeah. So somebody comes in, been diagnosed overweight, diabetic, 30-year-old, tell them you need to increase your exercise and you need to eat healthy. And the person goes home and it's unsafe to walk in their neighborhood. They can't afford the Y fees. Do you know what I mean? You go down through the thing that person is not that they don't want to exercise, but that could be in their way of actually being able to participate in their treatment plan. And
neighborhoods are beyond zip codes, and we know that that's how the healthcare system operates, is around zip codes. So we need to ask deeper questions about how they define their community and what they have access to, and what gets in your way is
exactly
a simple question to ask.
Most definitely, that's a great thing, and that's sometimes, and I'm really happy of the nurses that we have here today. Thank you for coming. The one thing that I kind of get disappointed sometimes about with these health literacy trainings is that we don't have more of the medical people. We have the people that are the case managers, the care managers, the navigators, the people who are now taking the people after they've met with the health professionals and trying to make sense of all the things that are going on. So it's really, we need to have a team, and like you're saying, asking those questions. How about even asking, like, if I can't take a antibiotic 4 times a day. I don't know what it is. I just cannot do it. I always miss a dose. So if the doctor comes in and just sees me, oh, you got a sinus infection, okay, we'll take this medicine, writes it down, and hands it. If they just wrote me the one that I have to take 4 times a day, I'm not going to do it. And not because I don't want to, but I just am incapable. And so say that's the only option is the 4 times a day, but somebody should be having a conversation. How do you feel about that? We could say, oh, you need to be changed to the Z-Pack. It's only 1 time a day. Or, okay, so you have to do this medicine, only one. How can we do that 4 times a day? Can you sit down with the person and kind of make a plan? I know it's really time consuming, but it's going to be more time consuming when they come back again and they're worse and they haven't gotten better. If you are working in the hospital and they get readmitted within 30 days, you're not going to get paid if they're on the Medicaid, Medicare issues. So the notion of it takes more time to do this, actually it will save time and money and improve your outcomes for your patients.
That reminds me of being a construction worker, where we would always complain, like, we don't have enough time to do the job right, but apparently we got enough time and money to come back and do it again.
Yes, exactly. You're right. You know, and that's usually one of the biggest resistors is we just don't have time. Like, there's no way we can do that. And you know what? It is extremely busy. Like, there's not one of you or any of the nurses or any of the doctors is sitting around playing cards, like I've heard, you know. You know what I mean? That is not occurring. They're overwhelmed and they're really busy. But at the same time, how do we make sure that it is meaningful? How many of you have been asked when you go into the physician's office or the emergency room, do you feel safe at home? Why do you think that's being screened or asked?
Domestic violence.
So it came up that, wow, you know, domestic violence is really an important issue, and that when they're in the doctor's office or in the emergency room, if we could screen for that, we might be able to do an intervention. This is how I've had my question asked. I'm sitting over there, the person's on the computer. Do you feel safe at home? Okay. While the person I live with is sitting there with me. So they asked the question and they screened it. They didn't see my body language. They didn't look to make sure that I understood even what that meant. Do you know what I mean? And maybe it isn't at home. Maybe it's, you know, in the relationship. But where I'm going with that is that health literacy can't be just another box we check. We can't come up with something that we're just going to say to the professional, you need to do this before they leave. Because it's going to become that rote of, do you feel safe at home? Kind of a thing. And so, if anything, we have to work together to find out how can we streamline and make things better for both the patient and us at the same time. I'm going to play a quick tape.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4, okay.
I would give her the 4 to 5, a tablespoon and a half.
One capsule.
That's right, 1 capsule.
1 capsule. I don't know what this is. That's
Twice?
Twice daily.
Okay. So how would you take this?
When I see it's not on there telling you how to take it. It say take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hypered? Hypered?
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
Yeah, I don't know. That's what I consider it.
Okay.
Being, you know.
Okay. But you know you have high blood pressure. Okay. But hypertension doesn't mean the same to you.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult to for me to take these pills because if they say 1 tablet twice daily, I don't know if they're talking take 1 in the morning, 1 in the evening, or take 1 in the afternoon or 1 in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
One of the ones that I cut off before we actually saw it because of time, that actually gets everybody every time, is Linda, who talks about she went in for having female issues and told her doctor that it just wasn't working, and he had told her that, well, we can fix that. Long story short, she went in, signed all the papers, had no idea what she was signing because she didn't want to tell them that she couldn't read it. And she's a filmmaker. She looked like, you know, if you were judging a book by the cover, like she would know it. 2 weeks later after the procedure, she came in and the nurse said, how are you doing after your hysterectomy? And she had no idea that she had had that. So that is why the informed consent is really important in making sure people understand that's usually the response is, wow, is that if you notice what they were doing on there, they were actually talking to the patient about it. Like, how many times has somebody sat down and said, can you tell me what this label says and how you're going to do that, kind of a thing. So it's really important to realize that this isn't just like somebody that you walk in and you can tell, oh, they have a reading issue. This can be, remember, only 10%, 12% of the population are proficient, 53 are intermediate, and 36% of those are actually going to have a difficulty with it. But health literacy, we need to remember also, the concept of health literacy is that a person's health literacy can be about the difficulty and complexities the demands that are being placed on it. Imagine you go into the doctor's office and you've been diagnosed with early onset Alzheimer's. I don't know about you, but I wouldn't be hearing a whole lot more about what was being said. And so think about the time if you go in and your loved one has had a really serious car accident. Are you really hearing what all the things are, or are you thinking about all the other stuff? So think about the complexities and the demands that the person is under. If they're really stressed, if they're a caregiver. Caregiving is another thing that you need to be really aware of, is that is a really challenging and amazing job that people do. And so it's really important to realize the stress, though, that goes along with that, and making sure that the caregiver is understanding as well. Because if you have somebody at home who relies on the caregiver, it's as important that the caregiver is health literate as it is the person that you're working with. For most of us, we don't need to know the economic impact. We just want to help people, and we want them to have better outcome, and we want them to be healthy. But sometimes our leadership, and I call them the bean counters sometimes, they need to know like the return on investment and why it's important. Why it's important is that in 2007, they estimated that between $106 and $238 billion can be attributed to limited health literacy. Readmission to the hospital, medication errors. We go down through and you can add it up. And that jumped from 1998, where it was estimated of 73 billion annually. So when we're in a time where we're looking and saying we can't afford universal health care for individuals, yet we have a $238 billion taxation onto the medical insurance, the individuals. This is definitely something that we need to take a look at. There are more than 100,000 older adults that are hospitalized each year due to medication errors. 1 in every 6 hospitalizations has to do with adherence issue to medications or adverse reaction. So just there, just taking the time to make sure that people are understanding their medication and how to take them. When you're age 65 to 79, there's an average of 14 medications. When you hit 80, it jumps up to 18. Imagine trying to make sure that you're taking all those medications properly and that they're not interacting, and you're taking one to counteract what the other one does. And you have 4 different physicians that are trying to do that, and you have a pharmacy. And you then, a lot of you in this room, probably have somebody come with a bag and drop it down and say, I have no idea what I'm supposed to do with this. Or they haven't thrown away their meds that they weren't supposed to take anymore, so they still take that one and the one that they were. Medication is a huge issue and something that we really need to take a look at. So that would be, if you're looking at something to do and implement in your own practice or in your own things, there in your packet there's a pill card that's through the Agency for Healthcare Research and Quality. And that is like, there's a template you can go on, but it's actually how to build an actual card with your patient, be able to show them, and I can show you the slides a little bit further too. But that's just a way that if you see somebody is struggling with it, to help them be able to visually see it. Because remember, if we're visual learners, this is another way that you can do that. Hospital stays increase with low literacy. We already talked about the treatment plans, but we're also more likely to have a higher mortality rate. They found, especially after heart surgery, that the number increases significantly of those who have limited within 90 days. They can tell the mortality rate jumps with the low literacy. How do you think it impacts access? Again, even knowing where to go. Being able to get there, having the funds, even if it's necessary. That's a big thing too. A lot of people with the access, it isn't just that they don't know how to get there, they don't know when it's an issue to go. I know of a man who lived out in Addison. who had a tooth infection, and he didn't go to the dentist and have anything done. He ended up going to the ER when it got really extreme. The gentleman passed away from a tooth infection because there wasn't the knowledge that that was something significant enough that he should go and get treated. A lot of times our upbringing or things like that is like you tough it out, you know, or you don't have dental insurance, so there's no way you can go and do that. Safety. Obviously it impacts safety if people aren't aware of what they're doing. My mother is a diabetic, and she does not eat the way she's supposed to. She does not follow her treatment plan, and yet when she goes in to talk to the doctor, the way that the questions are asked, are you following your diet? Mm-hmm. How's the things going? Oh, good. Yep, yep. But she has a new doctor who's really good, who says, well, tell me about your day. Because this doctor just spent 20 minutes trying to figure out how to change it, because the AC1 and all this other stuff was all over the map. So she's like scratching her head and doing all this stuff. They'd already changed the time before. And my mom got talking to her about, well, yeah, I'm walking, and we go over to the Walmart, and then, but on our way back, we treat ourselves and we stop at Ollie's and buy some candy, and you know, it's like, oh, time out. You know what I mean? So like when you actually get talking to the people. But safety-wise, here this poor doctor was trying to find out the best treatment options for her and couldn't do that. Another scenario with safety is the understanding. A gentleman came into an emergency room with high blood pressure. They put him on high blood pressure medication, told him to take it once a day. The bottle said take once daily. And within a week, he was back with passing out, fainting, really having all these symptoms that they couldn't figure out. And they did all these expensive tests, and they were just at a loss when finally one of the residents, who was also bilingual, looked at the thing and said, can you show me how many pills you've been taking? Because once means what in Spanish? 11. The man had been taking 11 of his pills a day. So it's really important. Like, people can talk back and say the things back to you. It doesn't mean necessarily that they're going to understand it. All other things is it's not always what it seems. That anxiety can reduce your ability to understand information. The language can cause an issue as well. Strategies. We're going to take a look at recognizing some red flags, but also creating a shame-free environment. That's really essential. Improving interpersonal communication is huge. The respect model. This is something that we had Dr. Anita Wright came down and did a cultural competency and consulting with us. And we were trying to figure out how do we incorporate cultural competence into this. And really what we found is it's in everything. And it goes back to this respect model. And it's about being able to find the ability to talk to somebody. We need to empower our consumers. I say consumers because it isn't just patients. We should be thinking about preventative. All health professionals, people at the gym, people in the community, how, you know, we are all health consumers. Universal precaution. And then the bottom one is becoming a health literate organization. We need to put it right into our mission. This needs to be something that is as important as being patient-centered, doing shared decision, because actually health literacy is the how to actually accomplish the patient-centered and the shared decisions. If they're frequently missing appointments, incomplete registration forms, that doesn't mean that they're just not cooperative. Sometimes it means that they're having a really difficult time and they don't want to either show that they are, they don't understand. Sometimes people get gruff and upset and we think, oh, they're just cantankerous. Well, it's because it's a frustration level and they're getting to the point where they can't hide anymore, that they can't understand that portion. And again, we talked about it isn't necessarily that they want to be not taking their meds. But if you see that somebody isn't, that's where you might want to check in and see why they're not. Can they actually name their medications and explain what they're taking it for? Can they identify their pills when they're looking at them? And can they give a coherent sequential history? The pills, a lot of I've seen is the brown bag. How many of you have heard about the brown bag with medications? You ask your folks to actually bring all the medicines that they're taking in with them in a bag, and then you put them out. And this is a great tool because you can see, wow, who's John Smith? On this bottle it says John Smith. Oh, that's my brother and he gave me his extra pills. That stuff happens. Or, these 4 pills you're not supposed to be taking anymore. Oh, or, you can start talking about how they're doing. Or you can see that they've got it right on task, everything is good, and you can move on. But that's a way to have somebody just kind of check in with them and make sure that they're taking the meds the way that you want them to do it. If they don't ask any questions, that's a big sign. That is something that definitely, we ask all kinds of questions when we're buying a phone. We want to know, all these things about it, but you get in there and you don't ask any questions. That's a good red flag. And a lack of follow-up on their referrals. We want to convey an attitude of caring, respect, and helpfulness. That will allow somebody to be able to share with you some of their vulnerabilities. Think about where they're sitting with you. A lot of times it's because they're vulnerable. They're either sick, they need help, and so then being able to actually open that door for somebody to communicate with, you need to be able to have that interpersonal connection. Aretha! Respect. Anytime I hear the word respect or you start to spell it out, how many of you the song just pops to your head? So the line that comes in is find out what it means to me. This is so crucial. I have seen that with the diversity trainings, what I call diversity fatigue. People roll their eyes, I gotta go to another diversity training. And they sit down, do you know what I mean, and kind of go through the motions. Some of that is because there's a frustration of, I'm never going to learn every single culture. I'm not going to know all of the nuances. I can't possibly be expected to know everybody's. And that's true. That you don't need to know everybody's cultural background, but you do need to know what respect is to them, because that's what people want. Is they want respect. And when you respect them, you have that bridge to be able to talk to them about how you're going to get through this. So the R is the rapport. Empathy, being able to understand where they're coming from makes a huge difference. Support, if they know that you're there to help them, it makes a big deal. The partnership, being flexible, finding different ways to do it. Sometimes it's really important to realize that the way that we have always done something is not the way that they have always done something. So how can you be flexible in finding a way to do that partnership that still gets done what you need to for the hospital or for your practice, for your programs, but at the same time is including them. Explanations, being able to check for understanding. Sometimes there are different cultures where, and this is hard for us because we're talking about being patient-centered now. That's the big thing. But some cultures, it is not the patient that should be spoken to. It is the family that should be. So you shouldn't necessarily have to know everybody's culture, but it doesn't, how hard is it to say, who should we give the information to? Do you want the information to be directly to you? How does this work? And asking the patient, because if the patient is like, I want you to tell my daughter or my son or my husband or my wife, and then you're respecting their culture and being able to do that. and that kind of trickles down into the cultural competence and up to the explanations, is explaining why you're doing things. So if you start to tell the patient and the family gets upset with you because you should be talking to them, if you can explain, well, this is what our procedure is, I didn't mean any offense by it, but this is, we have to make sure that the patient understands what medicine that they're getting. And trust, that's a big one. So again, implementing this into your daily practice, slowing down, using the plain language. Think about in your daily work, what are your languages that you need to make into living room language, plain language. Sally, yours are going to be different than JD's and Joel's. In each place that you work, you're going to have your own lingo that you throw around a lot to your to the folks you work with. I throw around FLGC all the time because it's a lot easier than saying the Finger Lakes Geriatric Education Center. But trying to figure out a way to make sure you're doing that. I want to show you one quick thing on the active voice.
Introducing Passive Voice Hits. If you love being passive, this 20-disc set can be enjoyed by you. Included in this exclusive collection is Whitney Houston's classic, You Will Always Be Loved by Me. Eric Clapton's The Sheriff Was Shot by Me, but the deputy was not shot by me. And the late great Marvin Gaye's It Was Heard by Me Through the Grapevine. Order today.
Wow, those songs aren't so catchy in passive voice. What's passive voice, you ask? Well, passive voice is when the subject of your sentence appears after the verb or not at all. Passive voice is wordy and vague. It hides who or what is doing the action in your sentence. And it makes your readers work harder to identify the subject of your sentence. To encourage transparency, we should avoid using passive voice and instead use active voice. Active voice focuses on the subject, making it clear who is doing what. It leaves little room for interpretation. Let's compare two sentences. The passive voice sentence, the form must be completed electronically, is vague. Who should complete it? You? Your attorney? Only people named Bob? Hi, Bob! The active voice sentence, you must complete the form electronically, is clear and direct. You can substitute any subject and it's still clear. How about the applicant, homeowners, taxpayers? Active voice gives your reader a clear message, so when you are writing any type of document, avoid using passive voice. You can tell your colleagues you heard this tip through the grapevine.
So that was just a corny little way to remind us that, because I know when it comes up on my Word and it says it's passive, I'm like, oh well, I like it that way anyways. But just remember when we're writing things and putting things out for folks that there's actually the active voice. It'll help a lot. Using analogies and pictures along the way. A friend just was recently diagnosed with breast cancer, and the doctor just sketched it out on a piece of paper with her, showing her how the different cells were. And she was able to then come back and she was telling me and showing me. And I thought, wow, that was a really great way to do that instead of just handing a pamphlet. She got the pamphlet in a big booklet, but she really was carrying around the piece of paper that he had taken the time to draw, talk about it, draw, talk about it. Limit it to the most important concepts and repeat it. The teach-back method is one of the most effective ways. Do you know that 40 to 80% of people will forget immediately the information that they were just told? And another nearly half of the medical information is remembered incorrectly. So if they remembered it, it isn't quite what they said to do. So that's really important. That's why the teach-back method is so important. And the way you do that is just checking for understanding at the end. The main thing is to make sure, again, it's not just to check the box of, tell me what I just told you. You know, because that will not be supportive in developing that respect. But at the, you want to put the onus on yourself to make sure that I did a good job explaining it. And then not, do you have any questions, but what questions do you have? And please take out, do you understand? Because that's where the head bob comes in. And most people don't have the confidence to tell you that they understand, or they don't want to be that vulnerable. So you may not get the truthful answer on that one. The Ask Me 3 is a really good campaign that you can actually do with your folks. This is a two-way, and I've got some handouts if you'd like them. You can also go to this webpage, and they have brochures and posters and things. And really what you're doing is you want to prep your patients that when they come to see you every time, they need to leave with 3 answers. What the main problem is, what they need to do about it, and why it's important to them. And so then also when you sit down with them, if you're also in that same mindset of saying what the problem is, what they need to do, and why it's important to them, it's a much quicker way to make sure that you're checking for the understanding. But the thing to remember is that even the most well-intentioned clinician cannot single-handedly overcome the health literacy barriers. And so I think it was Sally who was saying, who's dead on, is that we really need to try to do something statewide. We need to try to get some consistency, because right now there isn't even a consistent definition. So this is where we need to look, is at our healthcare systems, also at policy level. It will make a big difference. And the system can be health literate by providing equal, easy, and shame-free access to the delivery of health care and health information. So if you're wondering, how is an organization actually health literate, it's in making sure that they can balance the services and the complexities that they have. And so an organization can be anywhere from, or the systems can be anywhere from Medicaid to UHS, to a doctor's office, to the health department. So again, those systems are community-wide. So the universal precaution, this is what I think is really important if you leave with anything, is trying to make sure that whatever one of these strategies that you implement, say it is the teach back, that it is done each and every time with every patient, not just with the people that you think it should be, and that all literature is written at a 8th grade or lower level, that all of the time that you sit down and confirm for understanding or have clear communication, it goes for every patient, every person that you work with. Another way to do the universal precaution is simplifying the work environment. How many of you know what ambulatory services are?
Services that are in
I had to look it up, and I was like, oh, those are the walk-in. Like I
would have said ambulance.
Yeah, I didn't know, but how many times do you walk into the healthcare system and it's absolutely overwhelming? One of the big hospitals that I have to go to follow up with a neurosurgeon, it scares me. I get nervous every time, even though there's yellow lines and red lines and there's green desks and this and all that. It's like, I hope I get to the right place, kind of a thing. So it's making your environment clear when they first come in, using the words that people use. If it's your mammograms, don't put women's health, put mammograms if that's what they're coming for, but put what it is that people are going there for. And a lot of times people say, well, how can you have patient-centered care if you're doing the universal precaution? And actually the universal precaution supports having patient-centered, because remember, you're making sure that you're respecting each person, you're clarifying with them, you're checking in, and that's the best way to have a shared decision, is by going through universal precaution. The AHRQ, this will be on the handout, is a great place. It has a toolkit that if you want more information, you can get into that. And it actually has different tools. You'll see that there's, like I said, the brown bag medicine reviews, those type of things. And we're not going to get into necessarily all of these, but you do have the 10 attributes in your folder. I just wanted to show you where it says becoming a health literate organization. These are something that I'd love for you to take back and talk to your teams about. Because the one thing that we're finding is that you can have a real cheerleader of health literacy, but if you don't have the ability to have somebody behind you to either do the resources or ask the nursing staff, the doctor staff, the social workers, the whole interdisciplinary team needs to be on board with it. So take a glance at that. There's some different areas. The one place that you can make a big difference too is in your onboarding or your orientation. So think about it just as simple as, could you do the respect model with every person who came in? Could you tell them we do the teach back method with every person? You know, you can just pick one thing, but how can you add something small? Because again, remember, you're going to get a pushback that we're too busy to try to do something. But try one of those and really take a look at the literature that you are putting out. How's your portals, if you're using portals for people to get into? The other thing that I have in here for you in regards to the attributes is actually for you to kind of go through and think about 2 to 3 ideas that you'd like to work on, and then try to then match it with the attribute. And on the back, start with a SMART goal and write that down. And then you can take this to your team and say, I'd really like to try this. This is how we'll know if we reach our goal. These are the action steps, but these are really important too. Is the goal is important because what will be good about accomplishing this goal? So again, if you can put it into perspective of reducing the number of missed appointments, reducing the number of readmits, and then you start a date of which you started it. So there's some information on that. In there you had to create the pill. Also there's a mental health, language matters. A lot of times people will use words like, oh, he's just OCD. Well, we need to be careful about how we're using those words. We also need to know that if somebody comes in and we're talking to them and we say, are you depressed? No. But if they start talking and say, you know, are you irritable? Are you having a hard time sleeping? You know, again, it goes back to what our language is around that. And so there's a thing that's there as well. And let's see what else. What questions do you have for me?
I don't know if this is really a question, but one of the things we struggle with as far as language is the stigmatized language and sort of trying to figure out how we talk to clients so they understand what we're in their language, but right. The language they're using is stigmatizing, right? So even right. Like if we're talking about urine screens, they right. say clean and dirty. Yeah. We may be trying to get away from that because that's very stigmatizing, mm-hmm. but then they don't understand what we're saying. I know 211, we had this conversation around 2112 too, is how are you connecting with clients so they know what you're saying, but not in a way that's stigmatizing? Because if we're using right. the right terms, they don't know what we're saying.
Right, and I think it's like meeting them where they're at, and then transitioning and teaching them about that would be my thing, because you're right. If you start, positive and negative in the medical world is really confusing. A lot of people are like, oh, your tests were positive. Great. Oh, no. You know, this is when we want negative. So I really think that you have to meet people where they're at and then work to educate and say, you know, you call it dirty, you know, and then you go through that way and kind of even teach why you don't use that word, kind of a thing, would be my suggestion on that. But you're right. The other thing is that sometimes the words and the language that they use can be offensive.
Yeah, oh yeah, I'm a crackhead. I mean, yeah. People come in and say, oh, okay, so what do you mean by that?
Well, and they can also, like, I mean, the swearing, I mean, there are a lot of things in people's, that can be vulgar in the way they categorize things, and it's not reacting to it. Do you know what I mean? That's the word they do. You know what I mean? You don't have to use it, but you can make sure that they understand, kind of a thing. I used to do case management for HIV and AIDS. And so I would have to do the demonstrations of safe sex, needle, cleaning their needles, those type of things. And it really is meeting the people where they're at. The other thing that I would say is that you need to be able to measure each person individually. There are some people that you need to do more for to help them get to where they need to, and there are others that you need to empower them to do it. So when I was case managing, if JD came in and Carolyn came in, JD, I might help him a little more because I know he needs the help. I might make the phone call for him to make the appointment. Whereas I know you're very capable of doing it, so I'm going to give you the card and tell you to do it, and then I'm going to follow up with you. So you need to know that while it's universal precautions and checking in to see how much assistance that person needs to get there. And I apologize, we could talk, I'd love to do more of a full day of this. An hour and a half is a really short time to actually go over health literacy. But I will send you this PowerPoint as well as more resources where you can go and actually, there's a lot of videos. There's some trainings online that you can actually do. But again, I would say if you can get this in and share, and then you get your department or your colleagues excited, reach out to us and we can look at how we can do the best type of training for you. Is it coming in and scheduling something, or is it giving you like a 10-week bits that you could do in your staff meetings if you only get 5 minutes each staff meeting to talk about it? But it's really important that it's coming to the table to talk about it.